Welcome to this explainer. Today, we're actually going to unpack a pretty fascinating 1982 medical paper by Dr. David H. Nichols. It explores how surgeons managed to solve a highly complex structural failure right inside the human body. So, I want you to think of this not just as medicine, but really as biological architecture.
Here's our agenda for today. We're going to cover 1, the anatomical collapse, 2, the transvaginal solution, 3, patient profiles and demographics, 4, the 10-step procedure, 5, results and complications, and finally 6, the engineering takeaway.
All right, let's kick things off with part 1, the anatomical collapse, or what happens when primary suspensions fail.
To really understand the solution here, we first have to look at the core problem, which is known as massive eversion of the vagina. Now, this happens when the cardinal and uterosacral ligaments, think of these as the heavy-duty anchor cables of the pelvic floor, when they basically atrophy and lose their strength. And get this, it can happen months or literally years after a hysterectomy. Without those natural anchors, well, you get a complete structural collapse. To fix it, surgeons have to rebuild the normal access and depth, and they generally have 2 different ways to approach that reconstruction.
And comparing the two brilliantly illustrates exactly why Dr. Nichols does not recommend the transabdominal approach. Going through the abdomen establishes an anterior access, but the major flaw is that it leaves the cul-de-sac of Douglas totally unprotected. That actually predisposes the patient to a future enterocele, which is basically a type of hernia. Plus, it makes it incredibly difficult to repair a coincident rectocele without doing a whole second surgery. Now, contrast that with the transvaginal approach. This method uses the sacrospinous ligament as a rock-solid anchor and actually allows surgeons to do multiple repairs all at the exact same time. Which brings us right into part 2, the transvaginal solution, an elegant architectural blueprint. Let's map out exactly why this specific approach is so highly favored. By using the transvaginal route, surgeons are basically hitting multiple birds with one stone. First off, it's completely done through a single operative exposure. It also allows them to cut out coincident enteroceles, and by the way, those are 3 times more likely to happen with this specific type of vault eversion. On top of that, it permits appropriate colporrhaphy, meaning they can repair both a cystocele and rectocele right then and there, all while restoring that crucial, comfortable depth and access. It really is an absolute masterclass in surgical efficiency. Before we get too deep into the actual surgical mechanics, let's take a step back and think about the anatomical landscape right before reconstruction. It makes you wonder, who were the real people actually requiring this intense architectural overhaul? So let's dive into the actual demographics of the patients who needed this fix. Moving on to part 3, patient profiles and demographics, the 1630 cases. So between 1965 and 1979, Dr. Nichols treated exactly 163 patients. But what's really fascinating here is the ratio of when this surgery was actually needed. Only 36% were primary cases, meaning the structural fix was done at the exact same time as a vaginal hysterectomy. But the vast majority, a whopping 64%, were secondary cases. These were patients who had already undergone a previous hysterectomy, and unfortunately, their internal supports just failed later on down the line. When we look at the ages, the mean age for those primary cases was 67.6 years, while the secondary cases averaged just a bit younger at 59.2 years. But the really wild part, the patients overall ranged in age from 32 all the way up to 87 years old. I mean, that really highlights the incredibly broad human impact here and the massive relief this structural fix provided to women across so many different stages of life. Now, looking at the mean interval data really paints a picture of these secondary cases. This is the amount of time between their first operation and this necessary reconstruction. For abdominal hysterectomies, it averaged over 13 years. But look at subtotal abdominal hysterectomies. That interval was over 27 years, and the maximum range, it goes all the way up to 39 or even 44 years. It just goes to show that this anatomical collapse could literally happen decades after the initial surgery. It's almost like a slow-motion structural yielding over an entire lifetime. All right, let's head into part 4, the 10-step procedure, the construction phase. Let's virtually step into the operating room and trace the surgeon's hands. This first half of the procedure is really all about preparation and exposure. They start off with the hysterectomy if the uterus is still present, cut out any enterocele, and perform the anterior colporrhaphy. Then they carefully open up the rectovaginal space. By the time they reach step 5, they're penetrating the rectal pillar to cleanly expose and grasp the coccygeus muscle's sacrospinous ligament. And that specific ligament is exactly what will act as our new heavy-duty structural anchor. Now, the absolutely crucial point happens right here in the second half, specifically in step 8. After placing the Dexon sutures and starting the vault repair, the surgeon ties the fixation stitches. And here's the kicker. In this step, the vagina must be attached directly to the muscle surface with absolutely zero suture bridge permitted between the two. Like they have to be completely flush against each other. After that, they just finish up the repair work in steps 9 and 10. It is just meticulous, brilliant biological engineering.
Let's look at the aftermath in Part 5, Results and Complications. Basically, the building inspection. To his credit, Dr. Nichols transparently reports all the complications. There were 3 cases that resulted in a short vagina, 5 recurrences of the eversion, though those were actually all successfully reoperated on later, 1 laceration, and, sadly, 1 death. But I really want to draw your attention to those 2 cases of nerve damage. Noting this small risk of sciatic nerve trauma is exactly why Dr. Nichols strongly recommended using an absorbable polyglycolic acid suture moving forward. That way, if a nerve accidentally gets impinged, the suture will just absorb over time and allow that nerve to naturally regenerate. Pretty smart, right?
But let's zoom out and look at the big picture for a second. Even with those complications, an absolutely incredible 158 out of the 163 patients achieved a completely satisfactory result. I mean, that is an outstanding success rate for correcting such a massive, debilitating structural failure.
There was also one other really interesting functional note in the paper. Transient stress urinary incontinence might occasionally pop up post-surgery, but it usually completely disappears within a few months as the vaginal tissues stretch and settle in. This temporary side effect happens simply because restoring the vaginal length ends up straightening the vesicourethral junction. The tissues above the urogenital diaphragm basically just need a little time to adapt and stretch out, especially compared to the tissues below it, which are more fixed. It's literally just the body settling into its newly restored framework.
And that brings us to Part 6, the engineering takeaway: structural integrity restored.
Take a look at this incredible quote that perfectly summarizes the entire procedure. Dr. Nichols notes that the true result is the permanent attachment of the vagina by fibrosis and scarring to the muscle ligament complex. Ultimately, this elegant fix doesn't just rely on some sutures pulling things tightly together. No, it relies on engineering the body's own natural scarring process to create a permanent, lifelong anchor. The sutures, they literally just hold the framework in place long enough for the body's own biological mortar to set permanently.
Which brings us to a really fascinating final thought to chew on. If we start viewing the human body as an actual architectural marvel, complete with suspension cables, load-bearing walls, and heavy-duty anchors, what other complex medical mysteries could be solved with simple structural engineering? It really makes you wonder how an engineering mindset could revolutionize entirely different fields of medicine, leaving us to look at our own anatomy in a completely new light. Thank you so much for joining me on this explainer, and hey, keep looking for those underlying structures in everything around you.